Well, welcome everyone to tonight's National Fellow Online Lecture Series. A reminder, this is sponsored by the AMSSM Fellows Online Education Committee, the AMSSM Education Committee, and the AMSSM Fellowship Committee. I'm Dr. Lee Mancini, and I'll be moderating tonight's session with Dr. Nathan Cardoos, who I'll introduce shortly. Next week, our lecture will be on relative energy deficiency in sports. It'll be moderated by Dr. Laura Goldberg, and our speaker is Lisa Woodruff. Just a reminder that tonight's educational lecture serves as an adjunct to your individual program's educational programming, provides fellows with direct access to educational experiences with experienced AMSSM members, and at times invited guest experts in a variety of formats, and to assist in CAQ exam preparation. Just some ground rules for tonight's lecture. Please mute your device's microphone and turn off your video. I'll be monitoring the chat, so you can submit questions through the chat function. Include your name and program if you wish. You can put it in the full chat or put it into me, Lee Mancini, directly. I'll then ask the questions based on the questions you submit at the end. Tonight's CAQ session, we're going to save all the questions to the end after Dr. Cardoos has gone through all of his CAQ questions. And then after the program, please complete the evaluation, which will be sent at the end of the lecture. So tonight, we're pleased to have Dr. Nathan Cardoos running a CAQ question session. He is an assistant professor of family medicine at the Boston University Chobanian and Avedisian School of Medicine and the Boston Medical Center. He serves as the program director for the BU Primary Care Sports Medicine Fellowship, section chief for sports medicine within the Family Medicine Department, medical director of the Ryan Center for Sports Medicine, and team physician at BU. I can also say I've had the pleasure of knowing Dr. Cardoos for over a decade. He's one of our former fellows and is extremely bright. He gives great talks, and you're in for a real treat tonight. So without further ado, I'm going to be turning things over to Dr. Cardoos. I will monitor the chat for any questions, which we'll ask at the end. And take it away, Dr. Cardoos.
Wonderful. Thank you very much for that introduction, Dr. Mancini. I'd like to start just by extending my thanks and gratitude to the AMSSM for inviting me to speak tonight and allowing me to continue some of the great work that's been done by Dr. James Robinson and others prior. And I am honored to have Dr. Mancini moderating the session. As he mentioned, he's been a mentor and colleague of mine for over a decade, one of the hardest working people I've ever met, real passion for medical education, and a real all-around great guy. Just one slide before we start the questions. And that is to say that the majority of the questions in this session come from the 5th and 6th edition of the AMSSM CAQ study guides, with a few pulled from some earlier sessions. I would say that most of the questions that I picked today are on the more challenging end of the spectrum, and many of them require multiple steps of reasoning. And the reason for that is just to try to push your knowledge forward. I've tried to include some images and charts throughout to give some value add over what you would get from simply reading the books, because I know many of you will be going through these in detail. So hopefully it will be helpful for you to go back and look through these in the future as a reference. So without further ado, let's go to question 1. So it's a 15-year-old female with a history of epilepsy who wants to join the swim, soccer, and track teams. Her last seizure occurred 6 months ago when she refused to take her medications due to side effects. Adjustment of medications has allowed better compliance without recurrence of seizures, and medication compliance is verified. What is the best recommendation regarding her athletic participation? A, clearance to participate in all activities without restrictions. B, clearance to participate in track but not soccer or swimming. C, disqualification from all her desired sports. Or D, referral to neurology for additional clearance recommendations.
And we'll give each question about 30 to 40 seconds until we get sort of a majority consensus and share the results then.
All right, so the majority said A, clearance to participate in all activities without restrictions. We got some answers for B and D as well. And the answer here is in fact A. So the justification is that in most literature, 6 months of being seizure-free with appropriate treatment is considered adequate control. And those patients can drive and they can participate in sports without restriction, aside from skydiving and scuba diving, both of which could be lethal if they would have a seizure. They shouldn't swim, dive, or train in water alone, and any coaches should be aware of that. And also the athlete should be informed that a concussion could exacerbate a seizure disorder. Next question. Lesion to which of the following nerves caused the winging of the scapula seen in the picture below? A, long thoracic nerve, B, spinal accessory nerve, C, dorsal scapular nerve, or D, axillary nerve. All right, so we have the majority picking long thoracic nerve with some for B and C as well. And the answer here is B, spinal accessory nerve. All right, so of the 4 nerves here, the first 3 are all implicated in scapular winging. All are pure motor nerves. Axillary nerve is both a motor and sensory nerve, and that is not implicated in winging. So let's go through these answers and see why B is correct. So the spinal accessory nerve is also cranial nerve 11, and it innervates the SCMs and also the trapezius muscle. So if you look at the picture of the trapezius on the left, trapezius serves to both retract and elevate the scapula. So if you knock out trapezius, the scapula will sit in a protracted and depressed position. So you'll see lateral scapular winging with the shoulder drooping. And that's exactly what you see in this picture and in the picture in the question. So that's why that's the right answer. Long thoracic nerve, which is the most common answer here, that innervates serratus anterior. So serratus anterior is going to serve to protract the scapula and to hold the medial border of the scapula against the thorax. So again, if that muscle is not working, you are going to get medialization of the scapula with elevation off the body. So that's where you get medial scapular winging. So important to recognize that difference between lateral scapular with the shoulder drooping and what you see in this picture. Then finally, we have the dorsal scapular nerve. That is a rare cause of winging and it's subtle. The dorsal scapular nerve innervates the rhomboids and levator scapula. It's primarily going to function as a scapular retractor with a little bit of elevation, not as much as the trapezius. And you'll see this lateral winging with a subtle elevation of the inferior border of the scapula, the inferior edge, just like you see in the picture here. So try to lock those pictures into your mind. All right. Next question. A 30-year-old male with T6 paraplegia presents to the office with the desire to begin a wheelchair exercise program. He has been gaining weight due to a lack of activity since the injury several years ago. He wants advice on how to safely begin an exercise program. Along with advising proper equipment, carrying water, and avoiding hot or humid days, you also advise which of the following. A, wear tight leg straps to increase sympathetic tone. B, take 10 grams of carbohydrates every 30 minutes during exercise. C, empty his bladder and bowels before each workout. And D, have cervical x-rays to rule out atlantoaxial instability. All right, so most got this one correct with C. And so good job. I included this because I really want to talk about autonomic dysreflexia, which is the phenomenon this question is getting at. So this occurs with spinal cord injury at or above the level T6. And what happens is when there's a noxious stimuli below the level of the injury, this creates an exaggerated sympathetic response. So it starts with headache, sweating, increased blood pressure, flushing, anxiety, and then can progress to a medical emergency, which can even be fatal: cardiac arrest, intracranial hemorrhage, seizures. and it's usually caused by a distended bladder. But bowel impaction, pressure sores, fracture, sexual activity, anything you think that could be a noxious stimuli below the level of the injury can cause this. So if you're wondering, why this only occurs T6 and above, it's because in patients without a spinal cord injury, when you have a noxious stimuli, there's a sympathetic response, but there's a compensatory parasympathetic response that occurs. And in these patients with T6 and above, there's a compensatory response, but it's not adequate enough to compensate. If it's below T6, then your splanchnic innervation is still intact. So you can actually vasodilate the splanchnic bed, and that's enough to create the bradycardia and vasodilatation that you need to compensate for the sympathetic response. The incorrect answers here, A is referring to a practice called boosting, which has been banned by the IPC, International Paralympic Committee, since 1994, which is actually a way to induce autonomic dysreflexia to improve athletic performance. These athletes will, at baseline, have lower blood pressures. They're going to have lower cardiac output. And so by inducing a sympathetic response, you'll actually improve oxygen utilization and performance. B is referring to athletes with type 1 diabetes, and D is a recommendation for an athlete with Down syndrome. Question 4, during coverage of a cross-country ski meet, an athlete presents to the medical team after she finished the race. She's shivering and slow to respond to your questions. You suspect hypothermia and quickly determine her rectal temperature to be 91.4 degrees Fahrenheit, 33 degrees Celsius. Which of the following warming strategies should be considered first? A, encouraging the athlete to move as much as possible to generate body heat. B, administration of warmed IV fluids. C, extracorporeal blood rewarming using cardiopulmonary bypass. D, removal of all wet clothing followed by application of warm blankets. Boom, 100% for D. Nice job. All right. So the first thing you need to understand to get this question right is that this athlete has mild hypothermia according to the Swiss staging system. And this is an example of one of the charts that I put in here for your reference in the future. These different stages are categorized by the core temperature, but they're also by symptoms. So the characteristics you're going to see is with mild hypothermia, the patient will be conscious and shivering. For moderate, they're going to lose that shivering response. For severe, the patient will lose their consciousness. And then for stage 4, it's going to be no vital signs. And each of these stages corresponds with a recommended initial treatment that you can see on the right. Passive external rewarming is just putting something over the patient to allow them to retain their own body heat and generate heat. Active external rewarming is putting something on the patient that is warm, like a bear hugger or warm blankets. So in this case, the incorrect answers, A, was wrong because actually encouraging the patient to move can trigger arrhythmia, including VFib. And the other thing it can do is it shunts cold blood from the extremities to the core, further lowering the core temperature. B is wrong because administration of warm fluids should only be done after warmed IV fluids, which is active internal rewarming, should only be done after passive attempts are unsuccessful. And then the extracorporeal rewarming is really done for advanced cases. So it's definitely not the first thing you do for this mild case. All right, question 5. A 68-year-old man has severe knee osteoarthritis. His severe cardiac disease makes him a poor candidate for knee replacement surgery. He takes 81 milligrams of aspirin daily. He has no history of GI ulcers. His doctors are trying to add NSAIDs to his pain regimen. Of the following options listed, which has the lowest risk for severe complications? A, naproxen. B, ibuprofen plus misoprostol. C, naproxen plus PPI. Or D, celecoxib plus PPI. Hey, awesome. All right. Most people pick D, celecoxib plus PPI. And then the next most was C and then A. So the official answer to this question in the book, which was the 3rd edition, is C, naproxen plus PPI. However, I'd like to make the argument that you are all correct, that D is actually the better answer here based on recent information. So whenever, and I want to include this because as sports medicine doctors, we are commonly working with NSAIDs, and I think we need to understand when certain NSAIDs are more appropriate than others. So whenever you have a patient such as this who has cardiovascular risk, aspirin use, GI bleed risk due to age and the aspirin use, we need to think hard about which NSAID we use. So the classic teaching based on early information was that celecoxib would not be a good medication for this patient because of his cardiovascular risk. However, there was a trial called the Precision trial in the New England Journal of Medicine in 2016, had 24,000 patients with OA or RA, and they all were treated with either ibuprofen, naproxen, or celecoxib. And the study showed that there was a roughly equal cardiovascular risk across all of the patients. So that kind of put to bed this idea that celecoxib is at a higher risk than other NSAIDs for cardiovascular risk. In terms of GI bleed, celecoxib really takes the cake here. The COX-2 selective NSAIDs are better than non-selective NSAIDs like ibuprofen or naproxen. It is important to note that in this specific case, concomitant aspirin use negates that benefit. And then anytime you are using an NSAID for either a high-risk patient or for long-term use, say over a month in a low-risk patient, it's a good idea to use a PPI for gastric protection. And if they can't take a PPI for some reason, misoprostol is a reasonable alternative, although that's not generally well tolerated due to diarrhea, abdominal discomfort. And then finally, thinking about concomitant aspirin use. So someone's on a baby aspirin, non-selective NSAIDs like ibuprofen and naproxen compete with the aspirin binding site, and it actually lowers the cardioprotective effect of aspirin. Celecoxib doesn't do this. So some experts will say that if you're using a non-selective NSAID, you can take it at least 2 hours from the aspirin to help mitigate this effect. But in general, the Celebrex is going to be better choice. So overall for this patient, I think in all fronts, the celecoxib is a better choice with the PPI. And in my personal practice, I don't use a lot of celecoxib, but I do use meloxicam, and that is mostly COX-2 selective. And is similar safety and efficacy to celecoxib, and also is a little bit less expensive. All right, question 6. A 20-year-old female runner presents to clinic for evaluation of left lower leg pain. The pain is described as a cramping sensation and occurs after 1.5 miles of running. She is unable to specifically locate the pain. Examination of the left lower leg, knee, ankle, and foot are unremarkable. You decide to test her for exertional compartment syndrome. The anterior compartment at rest is 7 millimeters of mercury. 1 minute post-exertion is 31. 5 minutes post-exertion is 22. And the posterior compartment at rest, 12. 1 minute post-exertion, 27. And 5 minutes post-exertion, 18. Which phase of the gait cycle is most likely to be affected by the patient's condition? A, mid-stance, B, terminal stance, C, pre-swing, or D, initial swing.
Give this one another 10 seconds.
Hey, pretty good. All right, so we got answers across the board on all these, but actually 40% of people got the correct answer, which is D, initial swing. And this is a challenging question, and it's really 3 parts. So the first thing you have to know is what's the definition of exertional compartment syndrome and how do you diagnose that? And this is worth locking into your brain for the exam. Basically, if they're over 15 millimeters of mercury at rest, that would qualify as positive diagnosis. If they're over 30, 30 or over at 1 minute, or 20 or over or at 5 minutes, then that's all will qualify as chronic exertional compartment syndrome. The next thing you need to know is that in this question, then it would be in the anterior compartment. You need to realize the anterior compartment contains the foot extensors and ankle extensors, and then you need to know something about gait. And I've included the walking gait here because I like this diagram. I do realize it's slightly different than running gait. But you can see that I use that red box to show you the 4 different questions, question answers in order. So it was A was mid stance through D initial swing. We're looking at the dark leg here, and you can see that in mid stance, terminal stance, and pre-swing with the foot on the ground, the dorsiflexors of the ankle and foot are really not active. It's not until that initial swing and you pick the leg up off the ground that you need to activate those muscles concentrically in order to prevent the toe from dragging. And they're going to be active throughout the whole swing phase. When you have initial contact, they're again active eccentrically in order to brake. And then once you're down into the loading response in mid stance, then it inactivates again. So it's really that initial swing is the answer. So really good job. All right, question 7. An 18-year-old male Olympic cross-country skiing athlete presents to your office complaining of decreased exercise capacity. He feels like he is much more out of breath than usual and feels shorter of breath more than usual after his races. He shows you a video of him breathing after the race, and you cannot hear an audible expiratory wheeze but note labored breathing. You perform a physical examination and a spirometry test in the office, both of which are normal. What should be your next step? A, give reassurance that his symptoms will improve as he improves his physical fitness. B, start albuterol 15 to 30 minutes prior to exercise and follow up in 2 weeks for recheck. C, refer for eukapnic voluntary hyperpnea testing. Or D, refer for an indoor treadmill test looking for a drop in FEV1 by 10%. All right, good. We've got most for D. So we got 41% for D, 35% for C, and 24% for B. And the answer to this one is actually C. All right, so the key to getting this question correct is realizing that we're dealing with an Olympic athlete. All right, so for these athletes, the IOC recommendations are that EVH, this eukapnic voluntary hyperpnea testing, should be performed ideally in order to confirm the diagnosis of exercise-induced bronchospasm for a written documentation of necessity. So if you are not familiar with that test, what it involves is breathing a dry gas rapidly for 6 minutes and then performing spirometry at timed intervals afterwards and looking for an FEV1 drop of more than 10% for a diagnosis. Now, in terms of the incorrect answers, the first one is just wrong because improving physical fitness will not improve your EIB. B is a very reasonable answer. That's what most of us do with most patients is try some albuterol and follow up in 2 weeks and see if it helped. However, that's really best for non-elite athletes. The IOC says this is an okay strategy only if there are no resources for further testing and no referral pathway. And in another document, so the PPE document 5th edition, the direct quote is that using this strategy is not acceptable for the diagnosis of EIB with or without asthma for a therapeutic use exemption in national and international competitions. And then D, the indoor treadmill test, which most people picked, is again, it's a reasonable option, but it's not felt to be quite as accurate by the IOC, and it's not their preferred method. However, in a resource scarce setting, a sport-specific exercise challenge where you're recreating temperatures in the environment is a reasonable alternative. And ideally, they even say that EVH plus the treadmill test would be the best combination. All right. Question 8, a left-handed 13-year-old male baseball pitcher complains of pain over the medial elbow. He reports that the pain suddenly developed following a pop in his left elbow after trying to throw a fastball in a game. On exam, he has swelling and bruising over the medial elbow, pain with resisted wrist flexion, and tenderness to palpation over the medial epicondyle. He also reports pain with any flexion or extension of the elbow. Valgus testing of the elbow is attempted, but he is unable to tolerate it due to pain. Pulses and neurological exam are within normal limits. What is his most likely diagnosis? A, ulnar collateral ligament tear, B, medial epicondylitis, C, radial head subluxation, or D, medial epicondyle avulsion fracture. All right, so we get the majority picking D, which is the correct answer, the medial epicondyle avulsion fracture. And the picture here on the bottom right shows an example of what that would look like. So this is caused by an excess valgus stress in the elbow in children 9 to 14 years old in general. And a UCL tear can be caused by the same mechanism. However, that is usually in skeletally mature athletes. Medial epicondylitis just doesn't fit the description. It's usually a much more chronic issue and very uncommon in the skeletally immature. And then the last, the radial head subluxation is another name for nursemaid's elbow. That's that longitudinal traction injury that we get in kids, usually age 1 to 4, often from swinging them around by the arms. The big reason why I wanted to include this one is that I'm sure many of the fellows have heard this already, but it is important to lock in CRITO, which is the appearance of the ossification centers of the elbow. It occurs in a pretty regular manner across kids, starting at age 1 and every odd year to 11 years old, starting with the capitellum and ending with that lateral epicondyle. And the reason that this is important is that if you're looking at a pediatric film with an acute injury like this, if you don't know this order, you could mistake an avulsion that is displaced. So for example, if you see a kid and all you see is the trochlea ossification center, but no medial epicondyle, that should set off alarms because the medial epicondyle should be there. So that would suggest that was actually avulsed off and displaced and is now mimicking a trochlea center. All right, the fusion of these centers usually occurs around 14 to 17 years old for most sites for males. And the medial epicondyle generally is the last one to fuse around 15 to 18 years old. Question 9. You're evaluating an 18-year-old male freshman football player for his pre-participation examination. His past medical history is notable for 4 stingers that he has sustained in the recent football season, with each subsequent stinger lasting longer, but never longer than 1 day. All his events occurred in his right extremity. On his current exam, he has a normal cervical spine exam with full upper extremity strength bilaterally and normal upper extremity reflexes. Which of the following statements best describes the recommendation you should make regarding his participation status? A, he is cleared to participate without restriction given his normal neuro exam. B, he's cleared to participate without restriction but should undergo x-rays. C, he's not cleared for participation until he undergoes advanced imaging with cervical spine x-rays and MRI. D, he's not cleared to participate and should be referred to neurosurgery. All right, so most here picked C, which is the correct answer. Got some for A and B as well. And so this is referring to a stinger. A stinger is a transient brachial plexus injury, typically causes this radiating upper extremity pain with circumferential paresthesias and possibly some weakness. And it usually lasts minutes, but up to days. And this is kind of the classic teaching on return to play after these stingers. So after a first stinger in a game, that athlete can return back that game as long as they're pain-free, full range of motion, and normal strength. After a second stinger that same season, they get withheld from the rest of that game, and then they can return to play once their symptoms are gone and they have normal range of motion and strength for the next practice or game. And then after a third stinger, you withhold the athlete, obtain advanced cervical spine imaging, and then return to play when symptoms are gone. Imaging's normal range of motion and strength. So there are definitely people out there, experts, who would disagree with this structure. Many would advocate for imaging if the first stinger is longer than an hour. And there was a survey of spine surgeons in 2020 that actually suggested most would recommend an MRI after a second stinger. But I think for the purposes of the testing, this is a good structure for you. When we do this imaging, what are we looking for? Congenital abnormalities, cervical stenosis, disc herniation, occult fracture, cord edema, lots of different possibilities. All right. So question 10, which of the following is correct about acute zygomatic complex fractures? A, raccoon eyes are pathognomonic. B, pupil levels are unequal. C, these are the third most common facial bone fractures related to sports injury. Or D, involves a mandible and associated bony structures. All right, kind of dartboard for answers. We've got, yeah, it's kind of across the board here. So the correct answer here is B, pupil levels are unequal. And I'll go through this. So these zygomatic complex fractures are actually the second most common facial bone fracture in sports. The first would be the nasal bone, and the third would be the mandible. And with these injuries, you'll typically see signs of orbital injury. So you can see a step off along the orbit, unilateral periorbital edema or ecchymosis. You can see subconjunctival hemorrhage. You can see enophthalmos, which is a sinking of the globe back into the orbit. The patient can have double vision. And then finally, the pupil being unequal height, which was that correct answer. So there's this ligament called the suspensory ligament of Lockwood that you can see on the top right there, which is a blending of the sheets of the inferior rectus and inferior oblique muscles. And it helps to anchor the globe within the orbit. So if you fracture that and untether it, then you can get the globe sinking down or sinking back. And when you look at the patient, you see that their pupils are unequal. We can also see flattening of the cheek or paresthesias of the cheek. Now, D was incorrect because the zygoma is not directly connected to the mandible, so they're not typically associated. And then A, raccoon eyes are a sign of a basilar skull fracture, and those are bilateral and they're delayed, so usually 2 or 3 days after the trauma. I included this artist rendition. It's not super medically accurate, but I liked it to remember all the findings in a basilar skull fracture. So you get these raccoon eyes. You can see bruising at the mastoid process called Battle's sign. And then you can see CSF rhinorrhea or otorrhea, and then hemotympanum, which is blood behind the tympanic membrane. Basilar skull fracture, until you really look at pictures, it doesn't necessarily mean anything. It's the base of the skull, and it's usually involving the temporal bone, but it can involve the occipital, sphenoid, frontal, or ethmoid bone. But this is what they're talking about when they say a basilar skull fracture. All right. Question 11. Which of the following is true regarding anaerobic training and VO2 max? A, training will increase the VO2 max by increasing maximal heart rate. B, in healthy adults, cardiac output is the limiting factor in VO2 max. C, maximal stroke volume changes little with exercise training. Or D, training results in a more rapid rise in heart rate during exercise. Awesome. So we have answers for all of them, but most did get the correct answer, which is B. In healthy adults, cardiac output is the limiting factor for VO2 max. So in healthy adults, when someone is at maximum heart rate and stroke volume, so their maximum cardiac output, the ability of the body's tissues to extract oxygen has not reached its maximum. So it's that cardiac output that is the limiting factor in VO2 max. A is incorrect because maximal heart rate is fixed. It's really mostly based on age, not on training. In contrast, C is wrong because stroke volume absolutely can be augmented with training up to 100%. And then D, training, this says training results in a more rapid rise in heart rate. Actually, training will result in a lower heart rate at any given rate of oxygen consumption or VO2. Question 12. You're the team physician for Division I NCAA school that has several Olympic hopeful swimmers. A 19-year-old female long course freestyler is experiencing classic swimmer's shoulder with anterior shoulder pain during and after workouts. At what point during her freestyle stroke is the shoulder at greatest risk for subacromial impingement? A, the glide reach phase as the hand enters the water with the shoulder in full forward flexion lateral to midline of body. B, early pull-through phase until the hand reaches perpendicular to long axis of the body at 90 degrees of forward flexion. C, late pull-through phase from 90 degrees of forward flexion until the hand exits the water with the shoulder in extension. Or D, recovery phase with hand out of the water, elbow flexed, forward flexion and internal rotation of the glenohumeral joint. All right, again, answers for all of them, but most did get D, the recovery phase. So great job. Let's go through this one. So this is a diagram showing the freestyle stroke. And this is the stroke where most swimmers will train. So an elite swimmer might do 30,000 shoulder rotations a week in this stroke. So it's important to understand the mechanics of it. We're going to focus on the left hand here, starting at the top with hand entry. And you can see I've put in the letters of the question answers for the different phases. So that the first hand entry, the hand hits the water, glide reach with that shoulder in full forward flexion. And then it's pull through early all the way through late with the shoulder gradually going down. And then the early recovery when the elbow comes out of the water and that glenohumeral joints in flexion with internal rotation. So if you can imagine, if any of you are mimicking this at home, that early recovery phase is almost like a Hawkins test. And actually, the most common cause of swimmer's shoulder is impingement with supraspinatus tendinopathy. So it makes sense that this would be where they're the most at risk of developing that swimmer's shoulder. It's good to know, too, that when an athlete will start experiencing this, the coaches or the athletic trainer might be able to pick up on it because they won't bring their elbow as far out of the water to protect that shoulder. So the coach will say that their shoulder's dropping. So just a nice tip for them to be able to pick up on an early development. All right, question 13. An 18-year-old year-round soccer player comes to your office to get advice on proper nutrition and diet. He's healthy with no major medical problems. How much protein should he ingest daily? So A would be 0.25 to 0.3 grams per kilogram per day. B, 0.5 to 0.8. C, 1.2 to 2. Or D, 3 to 5. All in grams per kilogram per day. Oh, awesome job, guys. So 89% pick C, which is at 1.2 to 2. All right, so I included this question because I think it's just really important, both for the boards and for general practice, that you have an understanding of the basic macronutrient requirements for athletes. In terms of carbohydrates, this ranges anywhere from 3 to 12 grams per kilogram per day, and it really depends on the activity level in the sport. So higher requirements for the more endurance athletes or athletes who are training for longer periods through the day. And that's going to make up about 55 to 70% of their total energy intake. The protein, as you answered correctly, 1.2 to 2 grams per kilogram per day on the higher end for strength athletes, lower end for endurance athletes. And then the fat will make up the rest of the total energy intake. The incorrect answer is A, is really referring to the protein one should ingest after in the first 0 to 2 hours after a workout for early recovery. The 0.5 to 0.8 is protein for sedentary individuals, and then the 3 to 5 would be carbs for mildly active individuals. A really nice job on that one. Question 14, various maneuvers performed during a physical exam can help identify a murmur suspicious for the diagnosis of hypertrophic cardiomyopathy. Which one of the following statements is true? Going from standing to squatting or crouching down during auscultation causes less blood to return to the heart. B, Valsalva increases the flow, contributing to a flow murmur. C, a 2 out of 4 systolic ejection murmur over the left sternal border resolving during Valsalva is likely benign. Or D, Valsalva decreases the murmur of hypertrophic cardiomyopathy. Okay, interesting. All right, so we got some for A, B, and D with most picking B. So the answer to this one is the one no one picked, which is C, that a 2 out of 4 systolic ejection murmur over the left sternal border resolving during Valsalva is likely benign. So what I just described would represent a physiologic flow murmur in a well-trained athlete. So Valsalva is going to decrease preload, so that will actually help to resolve that physiologic flow murmur. In converse, hypertrophic cardiomyopathy is going to that murmur is going to get louder with Valsalva. When Valsalva decreases preload, there is less blood flow through the mitral valve. So if you look at the picture here on the top right, we have a hypertrophied thickened septum, and then a very narrow window through the blood where the blood goes between the mitral valve and that septum. With less blood, you'll get more turbulent flow and a louder murmur. So that's why Valsalva or standing, both of which decrease your preload, will increase that sound of the hypertrophic cardiomyopathy murmur. The incorrect answer, A, because actually going from standing to squatting will increase your venous return. B is incorrect because Valsalva decreases venous return and decreases flow. And then D is incorrect because of what I just explained about the murmur of hypertrophic cardiomyopathy. All right, question 15. A 15-year-old tennis player presents with wheezing and shortness of breath while playing. Criteria for moderate persistent asthma includes which of the following? A, symptoms 2 to 3 times per week. B, FEV1 of greater than 60% and less than 80% of predicted. C is nighttime awakening 3 to 4 times per month. D is using short-acting beta agonists 2 to 3 times per day for symptom control. Or E, minor limitation with normal activity. All right, we've got answers for A, B, C, and D. Most for A. And the answer here is B. So that's the FEV1 between 60 and 80. So I included this question because this type of question is fair game on the test, where they basically ask you to remember the diagnostic criteria for an important medical condition. In this case, it's the one from the National Heart, Lung, and Blood Institute from September of 2012, the diagnosis of asthma. And so this is a chart that I thought it would be worth at least looking at once or twice. So I included here in the red boxes the various answers. You can see the correct one is that 60 to 80 for the FEV1 % of predicted. For mild, persistent, and mild intermittent asthma, it's going to be greater than 80, and then for severe, it's less than 60. In general, the way I remember this stuff is that moderate persistent asthma is basically daily symptoms or daily use of your short-acting beta agonist. So if you're using it multiple times per day or throughout the symptoms are throughout the day, that's severe. And if it's a couple times a week, more than 2 times a week, but not daily, then that's mild persistent. And if you're using it less than a few days a week, then that's mild intermittent, or symptoms are less than a few days a week. For the nighttime awakenings, it's basically goes, a few times a month for mild persistent, a few times a week for moderate persistent, and then 7 times a week or daily for severe. So if you have a general idea of that, it'll give you a chance on this type of question. Question 16, an experienced high school basketball player has been experiencing bitemporal headaches over her high school basketball career, mostly during practices and during games. Which of the following is true? A combined OCP is the recommended treatment. B, neuroimaging is not indicated for exercise or exertional headache. C, treatment with Imitrex is the first sign of the basketball-related headaches. D, a trial of NSAIDs is the most appropriate initial treatment. E, the patient should be held out of exertional activities until a full workup is completed. All right, so we got most for D, which is the correct answer. A good number for E as well, and then B. So it's D, the trial of NSAIDs. All right, so this question is referring to a primary exercise or exertional headache. This occurs in young adults with this bitemporal throbbing headache that's brought on by exertion, and it typically resolves anywhere between 5 minutes and 48 hours after stopping that activity. It's more commonly seen with hot conditions, high altitude, and that initial treatment would be NSAIDs. Classically, this is indomethacin about 30 to 60 minutes before the known provoking activity. And occasionally people take it TID for prophylaxis. This is a completely distinct entity from something called a weightlifter's headache, which is a variant of a cough headache, and it's caused by Valsalva. It occurs immediately after that Valsalva, lasts for just seconds to minutes. It's in much older patients, 55 to 70 years old or so. And it's really highly correlated with posterior fossa abnormalities like a KRA1 malformation. Incorrect answers here. The first two are just because it's the wrong initial treatment. So it's not an OCP or Imitrex. We use NSAIDs. And then B is incorrect because neuroimaging is indicated. So anytime someone has not been worked up for this exercise headache before, or they have a new symptom, they should be getting an MRI and MRA. If they have an acute presentation, thunderclap headache, severe symptoms, it's concerning for subarachnoid hemorrhage, they're going to the emergency room, they're going to get a CT plus or minus a lumbar puncture. The last question is tricky. This is the one that most people put as an alternative answer. We actually, so for this case, for example, she's been talking about these headaches throughout her career. You don't need to hold her out just because we've identified it now. We can do the workup and allow her to continue to participate. It's only necessary to hold her out if these symptoms are severe, they're debilitating, or she has a focal neurologic deficit. Question 17, which of the following is true about the injury depicted? A, the index finger is most commonly affected. B, it is linked to the open grip due to the biomechanical forces that it generates on the A2 to A4 pulley. An isolated complete rupture of the A2 pulley should be treated surgically. D, MRI is required for accurate diagnosis of the specific injury. Or E, when indicated, surgery completely reduces bowstringing in most patients. All right, so most pick B here with answers for C, E, and A, and the answer is E. So when indicated, surgery completely reduces bowstringing in most patients. This question is depicting a finger pulley injury, and specifically multiple pulley injury, which is resulting in bowstringing. So if you look at the pictures on the top there, it's that C, the A2 and A3 rupture, and it's causing a significant dehiscence of that flexor tendon from the bone, which is causing that bowstringing appearance. So in terms of incorrect answers, the A is wrong because it's actually the middle and ring finger that's most commonly affected, not the index. B, because it's linked to a crimp grip, not the open grip. So an open grip, the rock climber will use their hand like this, compared to a crimp grip where they have more flexion at the PIP and actually a little bit of extension even at the DIP to give them more force. And that increases the risk of these pulley injuries. An isolated complete rupture of the A2 pulley should not be treated surgically. These generally do very well with some taping or splinting, rest from rock climbing, and then a gradual return. And then you don't need MRI for accurate diagnosis of this specific injury. You can see the bowstringing clinically. Even for the other injuries like an isolated A2 or A4 pulley injury, these are actually really nicely seen on ultrasound. You can actually just see that there's a wider gap between the flexor tendon and the bone than on the contralateral side. And that's your biggest clue. All right, getting some scribbles across my screen. I'm not sure how that happened, but all right, question 18. A 21-year-old male collegiate wrestler presents to the athletic training room complaining of a rash that has developed on his chest and back. He reports that it started the day prior during summer conditioning drills and got worse today during an agility workout. He also reports that it is quite itchy. He has a history of atopic dermatitis, but denies any exposure to new detergents, perfumes, or soaps. He also denies fever, chills, or new medications. He has not tried anything to treat the rash. On exam, you note multiple small punctate wheals surrounded by larger flares on the trunk, back, and inner arms. Some have coalesced into larger erythematous lesions. There are no signs of infection. Which of the following is true regarding the treatment of this condition? A, epinephrine should be administered because this condition often progresses to anaphylaxis. B, he should be withheld from wrestling until all lesions are dry and he has received 120 hours of antiviral therapy. C, oral corticosteroid should be administered within 24 hours of appearance of the Herald patch. D, oral cetirizine, H1 blocker, twice daily is the initial treatment of choice. Or E, topical tacrolimus should be used twice daily as an alternative to topical glucocorticoids to avoid skin atrophy. Awesome. All right, 75% picking D, which is the correct answer, and some for B and C. All right, so this question is referring to something called cholinergic urticaria. And this is characterized by these small punctate wheals like you see here. They're usually about 2 to 4 millimeters, and then surrounded by larger red flares that can coalesce, so it can look like a big red patch. And it'll typically start in the trunk or the neck, but it can spread anywhere throughout the body. And they'll often have an associated itching or burning sensation with them. It's usually the onset of this is going to occur in the second or third decade of life. So that college, high school age is perfect for the initial presentation of this. And it's a favorable prognosis. It usually self-resolves within 10 years at most. It's managed with cetirizine 10 milligrams BID. And it is so the first incorrect answer here was that epinephrine should be administered because it often progresses to anaphylaxis. In this case, this presentation, it's not likely that this progresses to anaphylaxis. However, there is a closely associated condition called exercise-induced anaphylaxis, where you can get hives like this wheel and flare formation due to exercise. Those wheels and flares tend to be bigger, so they're more classic size, like 10 to 15 millimeters. That condition is only associated with exercise, whereas cholinergic urticaria can be seen with passive warming, like taking a warm bath or shower, or even from stress. So that's one way to pick it out clinically. When I see someone with cholinergic urticaria from exercise and they haven't ever had it before, I do counsel them about the risk of anaphylaxis. I will give them an EpiPen, but it's not likely that progresses with this appearance. B is incorrect because it's referring to herpes gladiatorum. C is referring to pityriasis rosea. And E is incorrect because even though this kid has atopic dermatitis, this specific presentation with the wheal and flare and occurring acutely with exercise is just not consistent with that diagnosis. All right, question 19. The following exam findings can be seen with which condition? A, cubital tunnel syndrome. B, carpal tunnel syndrome. C, radial tunnel syndrome. D, Wartenberg syndrome. Or E, musculocutaneous neuropathy. All right, we have 56% for cubital tunnel syndrome, which is correct. And then we also have some votes for B, C, and D. All right, so this is a multi-part question. I think the most challenging part of the question is identifying that these two findings are representative of ulnar neuropathy. Once you know that, you just need to know that the ulnar nerve is associated with the cubital tunnel. Carpal tunnel with median, of course, radial with radial, and musculocutaneous is self-explanatory. Wartenberg syndrome is trying to trick you a bit. The Wartenberg syndrome is a compressive neuropathy of the superficial radial nerve at the wrist. It's also known as handcuff neuropathy or chiralgia paresthetica. And that just causes a loss of sensation or pain around the first web space there. So it's confusing because the first sign that you're seeing in the picture on the left is called Wartenberg's sign. So named after the same person, but completely different. To explain this sign, remember that the ulnar nerve innervates all the intrinsics of the hand with the exception of 3 thenar muscles and then the radial lumbricals. So when the ulnar nerve is not working, your palmar interossei are not working, which means you can't adduct the finger, the small finger. And the extensor digitory minimi has a ulnar deviation vector. So radian nerve or PIN is intact, but ulnar nerve is not. The pinky will stick out like that. Froment sign, you're asking a patient to grab a piece of paper like you see on the bottom left and hold it there as you try to pull it out. If the adductor pollicis is intact, when ulnar nerve is intact, then you'll see on the left. If you knock out the adductor pollicis, now you're going to compensate to grip that paper. You're actually going to use your flexor pollicis longus, which is innervated by the median nerve or AIN. So then you'll get that type of arrangement instead of this. All right, so that would be a positive test. All right, last question, question 20. You're working as the doctor in charge of coordinating a local outdoor endurance event. When planning such events, the American College of Sports Medicine recommends measuring the wet bulb globe temperatures and provides recommendations for each level. The levels are described as colored flags. Which flag recommends that those participants who are at increased risk for heat collapse withdraw from the race and others to slow their pace to match the conditions? A, black, B, red, C, yellow, D, green, E, white. All right, good. Most pick red or yellow, a couple for black. The answer to this is red. If you don't know the scale, then you don't really have a chance at this question. But so that's why I wanted to put it in here so that you can at least see the chart once. So a wet bulb globe temperature is basically a measurement that's trying to get at how hot it is, how hot it feels. So it's a composite temperature that estimates the effects of temperature, humidity, wind speed, and then visible and infrared radiation. And it's measured by a device like the one you see on the top right of the screen. They cost a couple $100, and it just gives you the temperature, the wet bulb globe temperature. So the ACSM has come up with these flag colors. So and they're organized by the wet bulb globe temperature, as you can see in the middle. So black basically says you should cancel the race or recommend that the athletes voluntarily withdraw. Red, which is the answer here, is that if you have participants who are at increased risk for heat collapse, they should withdraw, and then the other participants should slow their pace to match the heat conditions. Yellow would be that participants at increased risk for heat collapse should slow their pace, but everyone else should just be warned. Green is pretty much the sweet spot, decreased risk of both hyperthermic and hypothermic collapse. And then white would be actually risk of hypothermia. And that's it. Thanks for sticking with me through that tour de force.
Dr. Cardoos, what excellent job. Great high yield questions for all the fellows taking part in great teaching slides, and you timed it perfectly. So if anyone has any questions, you can put your questions in the chat for Dr. Cardoos. And then as a special thanks to Andy Meyer for running all the poll questions, all the behind the scenes technical work that he does every week for our National Fellows AMSSM online lecture series. And he also put in the SurveyMonkey feedback session for Dr. Cardoos's talk tonight. So I don't see any questions in the chat.
Great. Hopefully it was all crystal clear. Well, thank you, everyone. Have a great night.